Hi, everyone. My name is Rebecca Okanya. I am a DPT student.
My name is Cheyenne Malloy, and I'm an occupational therapy student.
And I'm Aubrey Moser, and I'm also an occupational therapy student.
We recently participated in the 2022 IPD simulation experience with a simulated patient experiencing physical symptoms and personal hardships due to long-haul COVID. And we really wanted to explore further the role of physical and occupational therapies on an interprofessional team. We had a patient named Amanda who was reluctant to enlist another team of providers via telehealth and reluctant to use traditional medications. Based on her case and what she was experiencing, it seemed like therapies were going to be some of the biggest influences in taking care of her. Our approaches to treatment were to, one, identify the activities of daily living that were most strenuous and offer activity modification strategies. For example, engaging with her kids was something that was really important to her. So offering strategies to allow her to play with her kids was something that was really important. Secondly, we taught the patient how to perform pursed lip breathing in order to alleviate some of the asthma symptoms that she was experiencing. And thirdly, and probably the most important, we met the patient where she was. We offered support and resources in her community, and we continued to educate about her ongoing condition.
We sent out a qualitative questionnaire to OT and PT students that participated in this experience last year. And some of the themes that we found in our responses was that there was an assumption of roles. PT was known as working with lower extremities, and OT was known as working for with upper extremities, and this is not necessarily the case. And one other common theme was that there is an initial lack of trust and belief in others. The group, or one quote was that the group did not seem to make space for PT interventions or consider what PT could do. And another was that I had to defend OT as a profession and why we were involved in the case.
So with those themes, when comparing those themes to our own experience, we did see the assumption of roles in our experience and had to explain our roles. And additionally, there was an initial lack of trust in the beginning. So when we first started, we could tell that we were all kind of acting from an individual perspective, and this quickly was known that it was not working, and we did have to pivot. To do this, we came together and we did work as a team, and we found that once we were collaboratively working with an understanding of each other's roles, we were then able to give better client-centered care, and we also left the patient with a satisfied treatment plan.
Wonderful presentation, by the way, Rebecca, Cheyenne, and Aubrey.
Thank you. Does anyone have any questions?
I do. So you mentioned that the occupational therapy and physical therapy roles were discussed and you worked them through. And you also put it in a historic context that somehow the OT role had been designated beforehand and the PT role designated beforehand. How did you, as a team, work that out?
Like during our experience in the IPD, like how did we challenge that?
Yes. Yeah.
Okay,
How did this experience help you work that through and come to a better understanding of your roles?
Oh, absolutely. So one thing definitely was that when people came to us with what they had expected that we were, or how we were going to contribute with this case, pretty much what we did was that we would just like re-explain our position and how we are assisting with all occupations of their life, not just like job or upper extremities, or well, you had the issue with the job placement, right? In your experience?
I think in my experience, like a lot of people thought that occupational therapy was really about the environment. And I kind of explained that Amanda's role, she had lost her role of being a mother, and that was something that was really important to her. And I explained that that was something that I can help with as an OT. So that helped our treatment because that was something that was very important to her. And I kind of came up with the idea of like, okay, maybe you could, she liked to read with her kids. And I was like, well, maybe you can listen to a book with your kids instead, like on low, and it won't cause a headache. But just like bringing that information because other people didn't know that like OTs help with roles of like a mother or a wife or something like that. So that was how I kind of educated my group in that area.
Other examples too were just, so one other aspect was that she didn't really want to start any new prescriptions. She didn't want to be prescribed any more that she was already on. So one thing also was that other physicians, when they would make a comment of like some kind of treatment plan, I would like speak up and say, well, as an alternative, we could try this and see how this works out. And so that was also another way that we were kind of informing those around us and what our position really can entail. So kind of like learning by doing.
Yes, it sounds like that was very effective for you.
Absolutely. I feel like too with the positions of OT and PT, both are very hard to explain. Both cover a lot of ground. You really can't say that in an elevator speech like we're taught all the time. Really, the best way to learn is to see it firsthand. And that is one thing that we think is like really amazing about the FT experience. And that was one thing that we feel should be continue more in all programs is that just really pushing for everyone to experience these simulations just so we can all see how every department works, not just your department. And especially helps with like if you're sending out prescriptions or when you're working or collaborating with other fields.
Yeah, well, thank you.
Yes, and to address Liz's question in the chat box, it says, what do you think helps most in understanding roles and responsibilities and busting some of those untrue myths? And I think it is like what Aubrey was saying about instead of telling people, well, we're going to have to tell people what we do, but that doesn't always work. It's really coming together and seeing it firsthand and how we can just come together as a team. And once we see how OT and PT are put into different contexts, then we'll understand after we see it instead of just saying it. Because I do think like a lot of stereotypes are just cut so deep. Like it's hard, like even before I came into OT school, it was kind of like, okay, OT is upper extremity, you know, it's like hard to not think that because that's kind of what you think if you're not in school for it, I guess.
Yeah, it's almost like it's like naturally ingrained just from years of being told that.
Yes, those are all important points. Rebecca's here. Rebecca, did you want to add anything to this conversation?
Yeah, I think it was really important to highlight the collaborative nature that already exists between PT and OT. I've been on a clinical rotation, so in the hospital where OT was kind of my best friend going and treating patients. So I think between the two of our professions, we know kind of how well aligned we are and our goals are the same and maybe our treatment approaches will be very similar. So it was really about coming up with our own identity as a team and then explaining that to the bigger team so that they could see us kind of as a force that could help together, especially where traditional medicine in this particular case wasn't what the patient wanted. So why not utilize a different method of treatment that may be more beneficial? But first we had to kind of explain what we can offer as a therapy for the patient.
Great. Thank you.
Hello, my name is Nikki Barrington, and I am in the allopathic medicine program at Chicago Medical School. And today I will be presenting a poster with Kim DiGregorio-Roth, who is in the Applied Nutrition program at the University of New England. Today we're presenting our poster entitled Interprofessional Collaboration to Overcome Patient Hesitancy and Increase Engagement. To start off with, we want to introduce you to our simulated patient, Amanda. She is a 39-year-old woman that has a history of hospitalization for COVID-19. At the time, she presented with severe cough, headache, high fever, and an 85% oxygen saturation level. She then spent 11 days in the hospital. 6 of those were on a ventilator. While she was in the hospital, she was diagnosed with hypertension and prescribed lisinopril and an albuterol inhaler. Since her discharge, she has struggled with long COVID symptoms, including fatigue, migraines, loss of taste and smell, poor appetite, and occasional bouts of coughing. Those symptoms have been really difficult for her to manage, and so her main goal is better symptom management, preferably using natural remedies rather than traditional medicine, so that she can get back to both her work and home life as usual.
Our team was able to meet with Amanda for 2 separate sessions. We had very different goals for each session. Session 1, we came in with a very set agenda. Our plan was to come in our very separate areas of expertise and offer Amanda what we thought she probably wanted. There was a little collaboration with the patient, with Amanda, and with each other as a team. And in the end, the patient was very overwhelmed and hesitant to try anything. During the break between sessions, we were able to decide to focus on the cues that we had gotten from her during session 1, namely that she was interested in all of the natural options that we had to offer. So this time, specialists each went in focused on that same goal, the goal of natural symptom management. When we did this, we found her much more receptive and encouraged and even eager to try some of the recommendations. We also included her partner, Mo, as part of her care team, which was helpful. At the end, our nursing student went in to provide some counseling and just an empathetic listening ear to Amanda and Mo, and they very much appreciated that as well.
So our main takeaways as a team from this were how important it is to gain clarity around a patient's goals, to reduce their hesitancy and increase their engagement with their own care. And secondly, how important it is to be able to pivot to better meet the patient's goals in trying to provide patient-centered care. And most importantly, showing the patient that you hear, understand, and believe them is incredibly powerful for both the patient and the care team.
Okay, Stephanie, moving on to conversation. Well, Kim and Nikki, again, excellent presentation. And I'm so impressed with what you were talking about, following cues from patients. But other people, do you have questions first? I'll get to mine then. So this following cues from the patient, I think you did a good job on your poster describing how that awareness grew, that you really needed to listen to the patient. And can you talk a little bit more about the process of your own awareness? Kim, I'll ask you first. We need to make sure we're listening to the patient.
I think in session 1, several of the team members, even you could just visibly see when they were to mention some sort of pharmacological approach to symptom management, kind of like a even step back from the camera from the patient, which gave us a clue that she kind of wasn't really interested in that. She also did a lot of like, I don't know. So it was like vocal in what she was saying. It was in her body language, how she was kind of backing away and kind of growing wide-eyed. Those things kind of clued us in as time went on that she was not interested in those things.
Thank you. How about you, Nikki?
I completely agree with Kim, that there were a lot of sort of nonverbal cues from the patient that what we were saying wasn't really getting through to her. And for me, it was really a good learning experience. And, my previous interprofessional experiences, I've learned that often the MDs are kind of made the center of the room, whether we want to be or not. Often that's the case. So a very good lesson in how to step back and let those other professions help her in a way that possibly, traditional allopathic medicine couldn't help her.
I think that's a very astute self-awareness, Nikki. And to be able to step back is challenging. Other elements of this experience that you thought were important that for the audience here to know about?
I think the most important thing really was how much the patient's demeanor changed, particularly when our nursing student really took the time to say, we believe you, particularly with long COVID symptoms or other similarly kind of invisible illnesses, so to speak. Patients interact with a lot of healthcare professionals and they don't necessarily feel believed about what they're experiencing. So how big that was in terms of getting her to engage with the care, just expressing that empathy and that we believe everything you're saying.
Mm-hmm.
I think too, I think too, being able to almost like onboard her partner as like a teammate in her care ended up being really great too. The difference between not having him present during the first session and then having him present, even when she was maybe starting to feel overwhelmed, he kind of like would step in and be like, yes, we can make that happen. I can do these things. And I think seeing them as a team really felt like it made a difference too in her care moving forward, is what I would imagine.
Excellent. I'm glad that your team had that experience. Yeah. Okay, I think it's time to move on. Am I right, Stephanie? Sorry that this is so quick. We could go talk about each one of these presentations for an hour.
Thank you.
Thank you.
Hilton, and I'll be presenting our poster on caring for a patient with a chronic disorder. I'm a student nurse in the ABSN program at UNE and worked with Joshua Smezdad, PA student at UNE, Elena Hagen, and Michelle Dupree, both UNE ABSN students. We were part of the long COVID IPTE event with the standardized patient, Amanda, and were supervised by Dr. Paul Segal. As we know, care for chronic disorders requires multiple parallel care processes, which puts patients at risk for fragmented care, decreased adherence, and increased healthcare costs. As we saw with our stimulated patient Amanda, long COVID is no exception. Amanda is a 39-year-old woman hospitalized in November of 2021 for respiratory complications related to COVID-19. Ultimately, she was intubated for 6 days. Since her hospitalization, she has had lingering symptoms of brain fog, shortness of breath with exertion, fatigue, and debilitating headaches. She has experienced a significant decline in her quality of life since then, related to these symptoms, and she states that she just wants her life back. Amanda was frustrated with her lack of progress. She was experiencing low self-confidence related to her family role, and she was burdened financially by her healthcare needs. To overcome these obstacles as a team, we approached Amanda's case with a staged approach to provide a holistic plan of care. So we identified her first priority and created a clear, attainable treatment plan, incorporating specialized healthcare team members when applicable. Once that was being managed, we explored her next priority stepwise, tackling one at a time to prevent the patient from getting overwhelmed, which is a very common occurrence with chronic diseases. So by setting focused, short-term, and achievable goals based on the client's context, we created motivation, optimism, and progress for Amanda. Further research has shown that the chronic care model and goal-oriented model are both effective approaches at managing chronic conditions. They aim to bolster the client with an emphasis on autonomy and collaboration. Through this IPTE experience, our team learned that by implementing a more holistic, client-oriented approach through both interprofessional and patient collaboration, we had the potential to improve patient experience, reduce healthcare costs, improve population health, and increase provider well-being. Thank you.
Questions from folks or participants, comments? Tell us about your thoughts and feelings about the chronic care and goal-oriented models, or anything else that you want to comment about this experience and how it brought the team together.
Yeah, well, because of how the model's designed, it almost like forced us to make sure that we're all, or saw each other all on the same playing level. And actually our first interaction with Amanda, we actually had it led by the PT instead of like coming in with our allopathic doctor or myself as a PA. We kind of wanted to make sure Amanda knew that we were more focused on her and what she thought she could do, and on the realistic like possibilities for her, instead of being like, all right, can you pay for this drug? Can you do this? We see that you've had these like complications. Like instead of forcing something to her, we wanted to ask like, what does she think she can do? And it really helped us focus on like her migraines, because we let her talk and we listened, and she said like, this is the biggest problem because I can't hang out with my kids. I feel like I'm failing my husband. And that's where we took our first step, was for those migraines.
Mm-hmm. Great, thank you. So there was a question in the chat about these two models, and the questioner was wondering, are there other models that you considered, or other models that could be used that you as a team considered?
We had actually really just focused, because we knew it was a chronic condition. So we, like, when we were doing our research, we looked for chronic care models. And we hadn't really come across anything besides this one, at least that had like research proving that it worked. I mean, we could have taken like more of a traditional approach, which is like, here, let's try maybe your albular hair, or let's give you like a llama or LABA combo, like let's try something else. And then maybe try to give her even like a COVID medication. And that maybe that's more traditional if it was just one provider, instead of being like, here, let's talk to PT, let's work on your breathing, let's do these exercises with OT, let's have them come to your house, maybe let's try to get a social worker involved. But nothing specific that we really ran into besides this chronic care model.
So it sounds like that though you did your research, these were the models that fit, and they were successful in bringing the team together, you said.
Yeah, absolutely.
Yeah, in your debriefs during your IPTE experiences, what was the process like there, Joshua, with regard to people's growing awareness of what this patient needed?
Yeah, so our debrief was, a lot of people had agreed that like the migraines was the most important thing, and that we had to focus on that, and that it wasn't just like a pharmacological aspect or approach, but that it was more like, let's get you moving around, because that's realistic for her. She was, I think, 45 minutes away from from like her PCP. So instead of like trying to make her drive, and she had a truck and that costed money. So instead of like having her come into the office, like what could we do for her that first visit, for like those first couple of weeks before our next visit, that she could start to see some improvements or kind of have some hope. And that's what I was like touched on, was that we gave her something to hang on to, and do once leaving after that first appointment. And she was super receptive to that, obviously, because she knew that she'd have to come in, she'd have to waste any money, but that these are things that she could, do for herself.
Wonderful. Well, so that to me, that identifies a lot of awareness that was growing on your team. Since you're the only one here, you get all the questions.
Absolutely.
And you're doing a great job. The other question I had for you was, what will you take from this IPTE experience with you into your professional career as you move on? Do you think? Have you speculated on that?
Yeah, I want to know my resources, and I want to know like what other providers, who they use and who they refer to, because I think more and more that is medicine. Like, medicine is no longer seeing one person, or just one specialist. It's seeing like a range of people, and although it can be complicated with like insurance, I think that's where we're headed. And so we kind of have to adjust financial aspects to that, because you need to see other people to get their perspectives and what they can do for a patient if something doesn't work out. Because obviously we had talked about like the way a PA or an MD or a DO may see something is different than the way a nurse or a PT or a social worker or an OT or anyone else may see something. So
Yes.
That was probably the biggest takeaway, is that we need to know our resources. We need to know who we can refer to and who's around us, who's local. And I think that's
And with whom you might want to have a consultation with around and join the team, perhaps, if they could.
Could you repeat that?
That you would refer, but also get consultation for the team from those professions, if you can. It's not always possible, but
yeah, that was something we did say. Like, rarely could we get like all 6 people on a Zoom call with a patient, but it worked out really well. If we could do that in an ideal world.
Well, Joshua, thank you so much for carrying all the responsibility, and our time was up. We need to move on, and great job. Thank you.
Yeah, thank you.
My name is Anik Mitul Eyang. I'm a Master in Public Health student. I was glad to bring out my experience through an interprofessional team in telemedicine settings to help over a patient named Amanda. Through this FT experience, I learned to apply and Through this FT experience, I learned how to bring out my public health knowledge and share my point of view with different specialists. It was an amazing experience, and I want to thank my faculty tutor. Finally, I want to thank Amanda, our standardized patient, who allow us to practice our knowledge. And all through Amanda's visit, we were able to set up integrated medical plan, combining a medical approach and a non-medical approach based on the research of community resources, able to help her aside of her treatment plan. It was a great experience, and I highly recommend all students to at least experience this once in their education. Thank you.
And thank you for taking on the task of presenting your team by yourself, your team's experience.
It was challenging.
I bet you did a wonderful job. Thank you.
Thank you.
And you were very gracious in your team. So what is your takeaway, Anik, from this experience in IPTI?
As a public health student, I was like, oh, what can I bring out to help over to find a solution to solve patient's problem? Because it was when I saw the patient, I read the patient case was only focused on a medical condition, and that's it. I say, okay, as a public health student, what should I do? How can I help? And it was very interesting to, by practicing the motivational interview, I started to record all our needs, and we went through, it ended up with a medical approach and a non-medical approach. And it was very interesting. I made researches about all the community support she can have in her neighborhood. And she was so happy to find that we are not only focused on her medical condition, but we help her to go through a chronic disease by helping her over finances, housing, try to find if she's comfortable at work. So it's like all the thing around, and she was very happy to through these approaches. Yeah.
Yes. So multiple approaches and multiple problems to be looked at. Issues, yes. Well, thank you. We have to move on to we're supposed to go to track 4 now. I mean, breakout room 4, excuse me. Okay. But thank you so much. And again, apologies for the technical issue at the beginning.
Okay.
Wonderful job. Thank you.